Morning, everybody. I think that everybody's being let into the meeting. Welcome all. This is the ASH Smokefree NHS Network event. And we're here today to discuss cytisine and varenicline. And it's great that so many people have joined. I think I was told that there's going to be probably 300 or 400 people joining all together from across the NHS and local government. So anyway, welcome everybody. And we're going to have an overview today on Varenicline and Cytisine, which are two new medications that have become available in the past 12 months in the UK to treat tobacco dependency. And it's really exciting because before that, we've really only had a couple of medications that we can use all types of medications that are both nicotine related in the form of dual NRT or e-cigarettes. But now we can extend our armamentarium, which is great news. A couple of housekeeping points. Could everybody please keep on mute? But it would be great to see people's faces. So if you want to keep your cameras on, that would be great. This webinar is going to be recorded so that people who couldn't attend can look at it, and it'll be one of the resources. It'll be posted on the ASH website, and also the link, I think, circulated, and there'll be some slides available and other resources. So this meeting will be recorded. If anybody has any technical issues, which can occasionally occur, please put them in the meeting chat or email admin@smokefreeaction.org.uk. Now, I just wanted to give you an idea of the agenda today. So I'm going to just introduce the session in a second with a couple of slides, and then we've got some fabulous speakers lined up for you. The first is my colleague Matt from Manchester, Matt Evison, and he's going to describe how he and the team in Manchester have rolled out cytisine and varenicline and some of the enablers and barriers locally that they have used. Then we have Kieran Reynolds, who is an advanced specialist pharmacist from the medicine governance team at Specialist Pharmacy within NHS England, and he's going to talk about the Varenicline PGD. Then we have my colleague Joanna Feeney, who is a Stop Smoking Systems Strategic Manager at Fresh and Balance up in the North East. And has developed a regional PGD pharmacy supply service for both varenicline and cytisine in the community. And I know that many of you are from local government services, and that's going to be really important. And just to be clear, that this webinar is really for colleagues both in the NHS and local government, but at times I know it might feel that it's more NHS focused. And then finally, last but not least, we've got Sophia Papadakis and Louise Ross, who will be describing some of the training and other resources available through the National Centre for Smoking Cessation Training. So it's going to be a fully packed webinar. It's an hour and a half. Everybody's going to have about 10 or 15 minutes to talk, but there will be opportunities for questions at the end. If you have questions along the way, please put them in the chat, and we'll also try and answer them as we go on. So I'm going to get started now. So Claire, are you able to pop my slides up for me, please? So I wanted to start by saying that, this is a life-saving opportunity. These two medicines that work in the same way, by the way, and we'll get onto that in a second, are literally life-saving. They are really effective. They are the two of the most effective medicines we have to treat tobacco dependency, and they are on a par with e-cigarettes for helping people quit smoking altogether. My estimate was that at the moment there are about 200,000 people per year coming through local government stop smoking services, and we identify about 200,000 people who are inpatients or in maternity services coming through NHS hospitals at the moment through the inpatient pathway. So there's a combination of about 400,000 people that are touching our services in NHS and local government, all of whom could potentially be provided these life-saving medicines. and help somebody quit smoking permanently, which of course then reduces the risk of comorbidities and exacerbations of a variety of diseases. For those of you who aren't aware, Varenicline has been in NICE guidance since it was launched back in 2007. It's it had a NICE technical appraisal, and it was recommended that all NHS providers have this on formulary and have this on stock. That was back in 2007. Unfortunately, it went out of use. The company took it off the market in 2021 due to some impurities found in the preparations, but it was relaunched this year in the UK by a company called Teva Pharmaceuticals. So it is now available again, and many of you will be familiar with it. Cytisine, which works in a very similar manner to Varenicline, has been available in Europe for some 50 years now. It was launched in the UK in January of 2024 and is also very effective and well proven in clinical trials. Both of these medicines are part of our armamentarium for people with tobacco dependency. And it's probably also good to say, again, I'm not sure how much everybody on the call knows how these medicines work, but unlike lots of our other NRT products, these are tablet pharmacotherapies. They do not contain nicotine. And we know that a lot of our patients and people using our services, there's a large proportion of them who don't necessarily want to use nicotine products. And so Varenicline and Cytisine offer them another choice. Some of you may be familiar with a new publication that came out last year from the British Thoracic Society on the clinical management of inpatients for tobacco dependency, and both Varenicline and Cytisine were included in that under step 6, discuss and offer prescribed nicotine analog medication. So both NICE have recommended Varenicline and are likely to recommend Cytisine when they update their publication in February of next year. So they're NICE recommended, BTS recommended, and we should be using these medicines in clinical practice. Next medication, please. Next slide, please, even. So we recognise that on this call today, there'll be people who are only based in local government services. There are going to be people who are based in NHS services, be they hospitals. There might be some primary care colleagues as well. We recognise the funding for both of these services comes from different sources, but however, both of these services often overlap. So in the NHS, when somebody's admitted as an inpatient, or for example, being seen in the community through maternity services or community mental health services, a lot of these patients start in the NHS, but then there's a transfer of care to our local government stop smoking services. So somebody might get started on Varenicline or Cytisine in the hospital, but then it needs to be continued when they continue their quit journey in local government. And in between these services, lots of local government services have their own stop smoking advisors, but we also know there's a pathway that includes community pharmacists. We also know that some hospitals do the whole treatment package for the whole 12 weeks via their hospital. And of course, more recently, we've got lots of smoke-free digital apps that also could provide these medications. So there are lots of providers of stop smoking therapies, but the two main ones at the moment, of course, are in the NHS and local government. And it's collectively that we need to think about how we provide for Varenicline and Cytisine to the patients using these pathways. Next slide, please. Locally in the Midlands, we started a pilot with the 11 ICBs in the Midlands to get going with Cytisine and Varenicline. About a year ago, we started with Cytisine, and then more recently, we started with Varenicline once it became available. What we worked out and what everybody described on the calls was that these are the general steps that everybody has to take. So on this call today, some of you won't have started your journey yet to providing Cytisine or Varenicline. And I would say these are the standard steps, and I'd like my colleagues who are speaking later to think about this as well and see if there's anything else to add. But I would say the very first step is getting it on your local formulary. For me, that means my hospital, but there's also a primary care formulary that these drugs need to get onto so that local government providers can also work with GPs to provide the drugs. If you're a hospital-based service, you also then need your hospital pharmacy to procure the drugs and then develop a way of being able to prescribe them. And lots of hospitals now have e-prescribing. So that e-prescribing system needs to be enabled to allow this to happen. And I suppose in GP practices who may then prescribe these drugs in the community for patients, they need to be able to prescribe them using their electronic systems. There needs to be a standard operating procedure and a patient group directive in the hospitals or in the community. Kieran's going to be talking about the standardized patient group directive that's now available that all of you can use and make your own. There are lots of standard operating procedures. I have one in my hospital. I'm sure Matt has his in Manchester. And I would say, don't try and reinvent the wheel. There are lots of resources out there, and I'm not sure that Ash and the team could provide some examples that then you can adopt. And that's really to describe how you're going to use these drugs, who's going to do the prescribing, what to do and to expect with side effects, etc., and how they might be managed. So an SOP and a PGD are a step that you'll need to take. There are patient information leaflets that we've developed and provided to our patients for both cytisine and varenicline. And a lot of these go through patient groups to make sure the language is suitable. And again, these have already been developed by lots of places, certainly in the Midlands, in the hospitals that have been using it. The next step is, of course, training. So for the TDAs in hospitals or stop smoking practitioners in the community to become familiar with both cytisine and varenicline, how they're used, how they're given, what the side effects may be, etc. And the NCSCT team will be talking about that. And then for those people who are in hospital and discharged, there'll be provision for ongoing supply at the time of discharge from hospital or outpatients, and how is it that patients are going to get their full course of treatment. For cytisine, it's just 25 days, and for varenicline, it's for up to 12 weeks. And then, of course, for community providers of stop smoking services, the question will be, how do you get supplies to patients? How do you continue supplies? And we know that people switch from, for example, NRT to maybe cytisine to then maybe an e-cigarette to then maybe varenicline. And how do we make sure that our pathways enable patients to receive these nice recommended treatments? So these are the steps that our 11 ICBs in the Midlands have taken, and for many of them we've started prescribing cytisine in at least 4 ICBs. Another 2 or 3 are coming on board in the next couple of months, and all of our providers are planning to introduce varenicline. Pretty much all of them in the Midlands have, I think, got them onto their local formularies and have started the rest of these steps. So I'm going to ask Claire to take down the slides, and then I wanted to introduce my colleague, Matt Evison, who's a professor of respiratory medicine in Manchester, and is going to take us through the Manchester experience with varenicline and cytisine. So over to you, Matt.
Brilliant, thanks, Sanjay. So am I slide sharing just before I start talking?
Yeah, they are.
Yeah, yes. So welcome everyone. It's amazing to see the numbers here for today's session. I guess this is the interest in these medications and what an important moment this is for us in the tobacco control world, having these new medications back and new medications. We've got such an opportunity in front of us to embed these. So I'm going to talk about the Greater Manchester experience. It's very, very similar to how Sanjay just laid out the steps, which is good to hear, and maybe just add a few points around that. So I'm going to talk a bit about how we've approached this as a region, and I think that's it's been really beneficial to start this process with a regional protocol for the management of tobacco dependency from a medical perspective. This has been through, so for our ICB for Greater Manchester, NHS Greater Manchester, we have the GMMG, Greater Manchester Medicines Management Group, and that's the vehicle through which we can approve new medications, consider optimal prescribing practices at an ICB level. And we wrote this protocol quite a few years ago, which has been really beneficial. It's been helped us have a position on nicotine vapes. It's enabled us to have a standardized NRT prescribing protocol. It's been a good protocol for helping the work we do in tobacco. And then when these medications are available again, it's been the natural or the obvious place to update that protocol first, have it approved, and it then makes all the steps after that a little bit easier in terms of formulary applications and formulary approvals. So once a medication is approved by GMMG, it then should be an open door at every local trust because that's been approved at a local level. I'll touch, just as Sanjay talked about, on electronic prescribing, the education part, and a few of the things we've done locally and progress so far. I seem to be showing this slide everywhere at the moment, just because I think it's such a brilliant bit of work, because Cochrane is such a trusted, it's such a methodologically robust process. And they've told us and demonstrated to us, the team that put this together, that these are the most effective treatments for tobacco dependency: nicotine vapes, Varenicline and Cytisine. So this, for me, just sets the standard of care. For a person that smokes at any touch point with the healthcare system, their right and our responsibility is to provide access and the opportunity to access these most effective interventions. And Varenicline and Cytisine are a key part of that. And that is now our standard of care. It's all, how can we achieve that standard of care? And we have to keep working until we are at that point where every person that smokes gets that opportunity. And that now is the moment, because they're now both available. We've got misinformation to combat about nicotine vapes and make sure everybody gets access to them. And I think it's just worth reflecting back, whilst Cytisine is new, and that's really exciting, we had Varenicline for a long time, and we had all the evidence, even at those moments, and we know the uptake of it wasn't where it should have been. So this is some of the national audit data from hospital-based tobacco treatment, and over every trust in England, over an audit period, there were just 3 people prescribed Varenicline. This was across times where Varenicline was available. So it's I think we've got to use this as a new moment, and even consider it a new medication, and make sure we get this embedded at scale. As Sanjay mentioned, I think the BTS framework is really good for inpatients. We hope it's a simple framework that if everybody implemented it, it's simple steps to make sure every patient gets optimal care. And just to highlight, whilst so nicotine analogues, Varenicline and Cytisine, are a specific building block in this framework, the other important bit is it just acknowledges how good they work in combination, and the inpatient settings are a really important part of that, because NRT is our cornerstone of managing and mitigating nicotine withdrawal. Very readily available, rapid onset, and we can start that immediately as somebody hits the hospital entrances and A&E and wards to mitigate that withdrawal. Varenicline and Cytisine, they take time to reach their maximal effect. So as an outpatient, that person may continue to smoke and reduce their smoking as the effectiveness kicks in, and then stopping. In the inpatient setting, in a smoke-free hospital, that can't happen. So NRT is the perfect substitute in that early part of the admission, whilst additional nicotine is needed, whilst these drugs take maximal effect. Was very much the thought behind the building blocks in the BTS framework, that it builds on each other, not one or the other. So these new treatments are really good for the inpatient setting, and they combine nicely with our existing practices. And I just wanted to highlight this systematic review that I think really did bring home some of that in terms of the value of combination therapies. We know Varenicline works really well. When it's combined with NRT, it's even better. So from our GM experience, I mentioned that we first developed this protocol. So it was 2019, so it's 5 years ago we first wrote this, and it was very much centered around NRT and having a standardized protocol for both inpatients, outpatients, in stop smoking services. And it was been a really good document for us. It's helped us in that work at a regional level. But then also became the key point when cytisine became available. So January 2024, we'd updated this with the introduction of cytisine and to align with the BTS statement. And very soon after, we got the brilliant news that Varenicline was coming back. And again, an update added because we'd acknowledged that it wasn't available in previous versions, and we could then take that away again. And there's nothing new in this protocol. It's just us and Greater Manchester putting it together and acknowledging what are effective treatments and trying to support implementation. So it's all stuff that's already there. And the way this protocol was written is that we identified very effective treatments, we identified effective treatments, and identified less effective treatments. So Varenicline, cytisine, nicotine vapes are very effective. Combination NRT is effective. We know that single agent NRT or bupropion is probably less effective, and that it's not saying this is where we start with this first choice treatment. We know a lot of that is driven by patient choice, but it's acknowledging that we do have some of those most effective treatments. And so this just lays out some evidence base and some of the prescribing around it. Cytisine, again, we've just summarized the evidence base, and by doing this it really helps our formulary application, because every formulary application has to have a summary of the evidence base, and we'd already been through this as a group and agreed it all, written it into our protocol, so it was very easy to reference and just present the prescribing regime. So after that had been updated and accepted, as I say, it made the formulary application much easier. And this is just a snapshot from that formulary. And there is a link. So the NCSCT very kindly put this onto their website. So if anyone is at the start of that journey and is doing formulary applications, then hopefully it makes that work a lot easier, because it's there. Just copy and paste and use the summary of evidence and anything in there that is helpful. I think I just picked out a couple of things because these were really central to our discussions as a regional medicines management committee, that you have to think about commissioning implications. That was a big question asked towards us. And cytisine at a 25-day course is £115. Looking at our data, it's approximately about 300 per treatment course for combination NRT. We supply vaping devices, as do many stop smoking services and NHS services, which about on average will be £150 for device and e-liquids, and Varenicline's around £180. So that 25-day course does mean it's a single prescription, so there isn't a need for repeat face-to-face consultations and potentially some efficiency savings there. So really the conclusion of that discussion is that it represents a cost saving for the GM system, and to have our medicines management group say that was very, very helpful. It really did make the rest of the conversations after that much easier. And these are all they're publicly available documents. So like many other organisations, they publish the minutes of their board meetings. And so this is taken from early 2024 and summarises the conversation that happened in that GMMG board meeting, by which they went through that evidence base, acknowledged its effectiveness, and acknowledged to approve it as a first line product in line with our updated guidance. And it went through an open consultation process as well, finally before that approval. And then when you look at the minutes from the board meeting afterwards, both the protocol and cytisine have been approved in GM. So as I say, I think that the timeline about using that protocol update, then the formula application, was a really helpful one. And so cytisine was approved in March, and it was then, for me, it's then over to my trust and how we then get that process done and the approvals through the local medicines management group. Very straightforward once it's had the regional stamp, and that's been stocked since the middle of the year, and we've been prescribing it since then. and a very similar story for Varenicline. When you go through the minutes and the notes of the G-triple-MG in terms of Varenicline, it was a much speedier process because this is a returning medication rather than a new one. But the conclusion was the same, that there were no commissioning implications for this. And since October, we've had it stocked and available. So at MFT, at my trust, so cytisine is available for inpatients, for outpatients. We use it in our lung health check program. In inpatients, we use it alongside NRT at the beginning of the journey, and we provide the full 25-day course. And that's very simple. For 25 days and 100 tablets, that just makes complete sense to provide all of that. Varenicline was a more in-depth discussion where ultimately we have, after much discussion and advocating, we provide the full 12 weeks of the Varenicline prescription as well as an initiation pack and the rest of the completion. And that's really the two key discussion points around that. Was if we created inequity versus cytisine, so one therapy where you get an entire course and another where you don't, we are potentially creating inequity. And equally, the availability and our assurance that if we started a course in hospital, that could be completed with ongoing prescriptions beyond discharge or via alternative methods. We didn't have that full assurance. I think things are still coming up through primary care in terms of being available and on prescription. It just couldn't really take the risk that we start a medication and it doesn't continue. So the full 12 weeks is being provided. And we've found since that both of them went live, there is an immediate engagement and uptake. So many patients are coming back for Champix, they will call it and say, I've had a course before and I wanted it again, or have heard about new medications and are seeking it out. So from the very first day, we've been prescribing, and I think last Friday was our busiest day of prescribing 6 courses in a morning's clinic from our tobacco dependency team. And so the logistics of that is just a quick screenshot of our electronic patient record. So we have made the transition to Epic, which has many painful parts to it, but there are really good parts of having a fully electronic patient record. And we have a cytisine and Varenicline prescribing group. So for our tobacco dependency advisors who are not nurse prescribers, and they see a patient and they've talked to them about Varenicline and they want to start that patient on it. In the ward setting, they have that, and they may be able to go to the ward doctors. In an outpatient clinic that they run, they need to come to us. And so we have a messaging group where if there's somebody identified, we will then prescribe it for them. And those the prescribing programs that Sanjay mentioned, these are all now built into Epic and what we call Hive. So the initiation pack is built in. We just have to fill in that for the first 14 days, followed by the maintenance pack, the 1 milligram BD then for 70 days beyond that. And cytisine is just the same. Its original name is cytisinicline. And so when we first launched this, and I went around everywhere saying we've got cytisine, I had 100 messages back saying I've tried typing it in, I can't find it. So so yeah, I have to just be aware that there's a longer name for searching by it. But that is all now built in. It brought some questions up really quite quickly in that, well, we've got 2 of them now, and how do you decide between the 2? I think generally what we've found over these last few months is it's so patient choice driven on previous experiences, their wishes of having a 12-week longer course versus a shorter 25-day course. We do talk about cytisine having reduced adverse effects versus Varenicline. I think cytisine is quite a difficult regime in the inpatient setting, from the 6 tablets a day to then up to 5 tablets a day to up to 4. Without that very specific this time, is it a PRN medication? Is it a regularly provided medication? In some ways, Varenicline's a little bit more straightforward than that. Cytisine has some cautions, which makes Varenicline a more obvious choice. We worked so hard to get over this mental health illness concern with Varenicline, and we quote the Eagles trial so much. for patients to get into that Eagles trial, they had to be stable for 3 months. There'd been no adjustments to their medications. That was one of the trial entry criteria, and we use that in terms of in the same way for prescribing varenicline. So we've got absolutely no concerns with someone with stable mental health illness. Even with unstable, it doesn't mean we can't use it, but really for our team, they come and get some advice from us. And it might be with cytisine that doesn't have those cautions within the prescribing guidance, that may be a better choice. And the only other thing I'd just add is that in a cancer pathway, which is one of the areas I work in, actually this rapid reduction in dependency I think can be quite useful with cytisine, and there's treatment coming on the horizon. So just finishing up with the education for this is so important. We've got to rapidly increase prescribing confidence quickly, and there are loads of resources. You'll hear about loads of them today. We've published a few on the Greater Manchester Make Smoking History website. They are seminars on vaping, on cytisine, on varenicline. It's both slides and a voiceover to it, and they are publicly available as other guidances. We've also just launched a Smokefree NHS toolkit for hospitals, and within that, it talks about the importance of smoke-free steering groups. We've listed within that one of those responsibilities of being the implementation of cytisine and varenicline. We've put into that toolkit that's shared across all of our hospitals currently and is undergoing an implementation phase what a tobacco dependency clinical lead is, because we need these clinical leaders to drive these things in hospitals, in any healthcare setting. And again, one of those responsibilities being ensuring equitable access to these highly effective treatments, and through PGDs, through everything else. And that smoke-free policies should include cytisine, varenicline. How are we going to ensure access to these things? Our PGDs are all now currently been submitted. I know we've got a national varenicline one, there's a national cytisine one coming. Again, we've shared the ones that we've submitted previously, if they are helpful to anyone. The only reflection I've got from the PGD is that we were really challenged about using it in an inpatient setting, a PGD in an inpatient setting, because there's prescribers nearby, and a PGD is when there's that availability isn't there. And we really had to fight quite hard for this. So if anyone else comes up against that barrier, we actually had to write, the text in red comes directly from our PGD. We had to write in the importance that if we don't have that PGD, we risk that that medication isn't prescribed, or that person on the ward doesn't have the prescribing confidence, or it's delayed and it doesn't happen, and we will miss that opportunity. So just be wary of that. So in conclusion, I think it's such an important moment right now. We've got these medications that work so well, and we need clinical leaders. We need that at regional level, at trust level, to drive this forward and drive the framework by which they can be prescribed and accessed, and then rapidly increase our prescribing confidence across the healthcare system, as one part of a hospital-wide approach to tobacco dependency. And this is now our new standard of care. Every person that smokes should have the opportunity to access cytisine and varenicline as part of their treatment. And I will stop sharing there.
Brilliant, man. That's great. Just as ever, fantastic work. And I think you've been seeing all the claps that have been coming up on the screen. So clearly it's very well received, and some brilliant resources that you've pointed people to. There are some questions that have sort of been coming up in the chat. If you're able to do the ones that are relevant to you, that'd be awesome. We're going to do a Q&A toward the end, but there is still quite a lot to get to. So Matt, again, thank you. Brilliant work as ever, and great presentation. Now, next up, I wanted to introduce Kieran Reynolds. He's an advanced specialist pharmacist for medicines governance at the Specialist Pharmacy Service, and he and his team have developed a Varenicline PGD. And so over to you, Kieran.
Afternoon, everyone. Can everyone see my slides?
Yep, they're up.
Perfect.
Thank you.
So thanks again for the invite to speak to you all today. As Sanjay has said, my name is Kieran Reynolds. I'm a pharmacist, excuse me, within the medicines governance team within NHS Specialist Pharmacy Service. And I'm going to give you a quick run through of the smoking cessation patient group directions, or PGD templates, that we have developed and are currently in development. So your first question is probably, well, who are SPS? Well, we're a service that is commissioned by NHS England. We span all 7 NHS England regions, and our objective primarily is to work together to do once and share. And we provide advice and guidance to all NHS or NHS commission services on buying, making, and using medicines. Our role within the development of national PGD templates came across as a result of the Lord Carter of Cole's review into inefficiencies in the NHS, which recommended the standardisation of the development of PGDs and other medicines policies and other organisational governance documents. And the aim of this is to help to reduce duplication and help release local resource that can be redeployed elsewhere. And we are responsible for the development and maintenance of a range of PGD templates that are used nationally. The most commonly used ones that we have are in reproductive and sexual health services, also in ambulance service, radiology, and now smoking cessation. So what is a PGD? Well, it's a written instruction which allows the supply and/or administration of a medicine in the absence of a patient-specific direction or a PSD, a prescription, or a legal exemption as laid out within the law. And they can only be used by registered healthcare professionals listed within the legislation. So non-registered staff cannot work under a PGD. And PGDs are not prescriptions, and I'll give you an analogy in a little bit. And as Matt has pointed out, there may be some resistance in using PGDs, and this is due to NICE's standpoint, which is that PGD should only be used where there is no other suitable legal mechanism for the supply and administration of medicines. Now, when a PGD user works under a PGD, they do so autonomously. So they're responsible for assessing that the individual meets the criteria set out in the PGD, as there are no deviations allowed. So clinical judgment cannot be used to supply or administer medicine outside the criteria specified within the PGD. Registered healthcare professionals must only work under a PGD when they're listed in the legislation, so their professional group is listed in the legislation as being allowed to work under PGD. They are fully trained and competent to work under the PGD, and they have been individually assessed and authorised to work under that PGD. And no delegation of responsibility is allowed. So all activity that includes the consent, clinical assessment, the supply and administration, and record keeping have to be undertaken by the same individual. So the analogy that we often use is prescribing is an all-you-can-eat buffet. You can tailor the plate to the needs of the patient, but a PGD is a set menu. You're either in, you're out, no changes, and no substitutions allowed. So we have developed 2 PGD templates. The first is Varenicline, which was published in October 2024, and then Cytisine or Cytisine will be published once the NICE guidance is published endorsing its use, and that guidance is expected to be published in February 25. So these PGD templates have been developed with the support of NHSE and other specialist stakeholders working within clinical practice, including doctors, nurses, and pharmacists. And PGDs are an option for smoking cessation services to use. We hope that these and other PGDs help facilitate assessment and treatment initiation on the same day, shorter and simpler treatment pathways, and enable non-prescriber-led services to prescribe prescription-only medicines. So none of this work could be done without the help of the Short Life Working Group, whose advice, comment and clinical review is paramount to the success of this, and this is the Short Life Working Group for our Varenicline PGD. Now, for many services, getting PGDs into operation is a brand new step that they have to undertake. Now, I'm going to give you a summary of the steps that are required to get it into operation, but we've also developed a 2-page document specifically for smoking cessation services that we will share after the webinar that will help you kind of digest it at your own pace. So the first step is that the PGDs have to be clinically reviewed and then signed by a senior doctor, a senior pharmacist, and then any other professional group representative who'll be using them. So this is most commonly nurses. The PGDs then have to be authorised by what is defined in legislation as an appropriate authorising body, and that's most likely an NHS trust, a foundation trust, or a local authority. And just to note that where an independent healthcare provider or a charity provides a services which is commissioned by an NHS trust or local authority, the NHS trust or the local authority is the authorising signature. Now, the identity of who will sign on behalf of that body will be dependent on the organisation's governance structure, but this will be a well-trodden path for other services within trusts and local authorities, so somebody will be able to answer that question within your own locality. Then the PGDs should be reviewed through the organisation's PGD governance structure. This is most commonly within an NHS trust, is a Drugs and Therapeutics Committee or Medicines Management Governance Oversight Group. And again, your local pharmacy team will be able to provide you with more information about who this is. You then need to determine what relevant training needs to be completed so that practitioners can be assessed and deemed as competent to work under these PGDs. And these resources or training resources can be provided either by local or national resources. And I'm sure we'll hear about some of them later on today as well. And then the final step is the supply of medicines. So supply of medicines under a PGD requires medicines to be overlabeled with the dosage instructions and address on the service, as well as space for the individual's name and date of supply to be written on by the PGD user. The only exception for this is a registered pharmacist working within a registered pharmacy premises who can dispense it. Again, liaise with your local pharmacy department or team to determine how you can acquire these overlabel stock. And this is an example of an overlabeled label for a treatment for hepatitis C. So it gives the medication name, the dose and frequency, any special instructions, the address of the dispensing pharmacy, and then space for the patient name and date of supply. So to surmise, so these smoking cessation PGDs, so Varenicline published in October and Cytisine coming in February, are an option for services to use. They do require local sign-off before they can be used. And for the majority of services, they will require supply of overlabeled medicines. And we recognise that they will work for some services, but may not work for others, but we hope that the majority of services will be able to use them. If you have any questions, you can always contact us on our email address, which is shown here. And all our resources are available for free of charge on the SPS website. Simply go on the toolbar, guidance, and then PGDs. Does anyone have any questions?
So Kieran, I think
Whistle
the
stops
questions.
store.
Yeah, that's great. No, thank you very much, Kieran, because I don't think everybody will be familiar with PGDs. And remember, a lot of colleagues on the call are from local government, and I think a lot of the stop smoking practitioners in the community aren't necessarily registered healthcare workers. So I don't know that they would be able to necessarily use it, but there may be others. So I think Matt had mentioned outpatient areas and then using PGDs with maybe some nurses and who are registered, and so there may be a usage there. And I think that I'm guessing a lot of local government services are looking to mechanisms that might be helpful. And community pharmacy, which we've not got a speaker on today's webinar, maybe another option, but we can talk about that in the Q&A. So there was one question that I did spot for you, Kieran, in the chat, and that was, is there an SPS service in Northern Ireland? And does your PGD apply to Northern Ireland, I suppose?
So SPS is commissioned by NHS England, so all the advice and guidance that we give is tailored to legislation and practice within England. All our resources are available free of charge, regardless of your IP address. So if you want to use our PGDs, you are more than welcome to, but you need to be aware that these are designed specifically for use in England. So you need to tailor them for your own kind of local services.
Okay, brilliant, Kieran. Thanks ever so much. Right, we're on time at the moment, which is fabulous. I'm going to introduce our next speaker, who is very lovely, Joanna Feeney, who is the strategic manager at Fresh and Balance, presenting work that is being done there with local authorities. So this is really important, Joanna, because I didn't want it to be an all NHS focused webinar, and there's lots of community services who are desperate to get Varenicline and Cytisine available in their localities. So some of the work that you're going to describe, I think, is going to be really helpful to colleagues on the call. So over to you, Joanna.
Thanks, Sanjay. Absolutely. And I think just to kind of add that, you know, we are obviously working really closely with our community pharmacy colleagues as well. So this is an approach that we have in the Northeast, which would be a PGD via a community pharmacy supply service. So I'm just going to share my slides if that's okay. So yeah, as Sanjay says, I'm Joanna Feeney. I'm the Stop Smoking System Strategic Manager at Fresh, and Fresh is the regional tobacco control programme that covers the northeast of England. So I've been asked to share what we've been up to in the North East to enable the provision of Varenicline across our 12 community stop smoking services. And briefly, this is what I'm going to cover today. I'm going to talk through a little bit of the background context that led us on our journey towards this regional PGD. I'm going to talk about how our proposal was developed, highlighting some of the identified benefits and how we've gone about putting the plan into action. I'm also going to briefly mention our parallel work stream that's underway to ensure that Varenicline is also available within the trusts in the North East, and the timeline that we're working to deliver this on, as well as some of the challenges that we're facing. But I'm going to start with the caveat that this is all a work in progress. So this is just a little bit of a background. We have 12 local authorities, as I say, in the North East, and they deliver a range of different models of stop smoking services, including one that was in the middle of a retendering process back in March when we started this piece of work. At that time, Cytisine had just come onto the market, and we were expecting Varenicline to be back on the market, as I say, in the autumn. The ICB had recently harmonised its formulary from a single ICB formulary from the 3 previous ones. But there had been a number of concerns that had been flagged by prescribers to the formulary advising group about it being confusing with contradictory, outdated information. So, for example, there were notes on to say that in some areas you couldn't prescribe this medication, or in other areas not prescribe this medication because it could only be issued by a certain stop smoking service. There was also a lack of clarity around, for example, bupropion, and all of this was just acting as a big barrier for prescribers across the North East and North Cumbria. So we felt it was the perfect opportunity to review the formulary with a view of adding cytisine, but also to update it to ensure that Varenicline and all of the other stop smoking medications were RAG rated as green, as suitable to be initiated in any setting, removing the outdated local commissioning information in order to reflect the changing landscape of the North East stop smoking system. So that was kind of acknowledging that stop smoking services were not the only ones that were delivering stop smoking support anymore. Within the North East and North Cumbria, we do put the person who smokes at the heart, at the centre of everything that we do, so that they have the choice in how they quit and where they quit smoking. So this ensures that we can maximise that system-wide impact by having all of the effective stop smoking aids that were mentioned available in all of the services that we have. And we knew this wasn't going to be a quick process, from, as been mentioned before, getting the formulary updated to agreeing the appropriate prescribing processes across the different services and settings, to ensuring that it's stocked in pharmacies, providing awareness and training sessions, and then the ongoing kind of review and monitoring of it. So what did we do? Well, we first undertook a mapping exercise of our local stop smoking services, looking at what their current processes are to issue medication. So, for example, where there were NRT voucher schemes in place, how they worked, did they have e-vouchers, paper vouchers, what systems were used, how they had previously provided Varenicline, whether they had any plans following the launch of cytisine, or any intended processes in development to support the supply of Varenicline once it was back on the market. We also did scope if there was interest in coming together as a region to have a single PGD. In addition to the stop smoking service mapping, we also worked closely with the Tobacco Commissioners Network. Some of the tobacco commissioners did have previous experience with Varenicline PGDs and stop smoking services, though I think it's fair to say the majority didn't. Since the pandemic, we also received a lot of feedback that engagement with primary care and pharmacy had declined, and that there was limited capacity now within public health teams to kind of pick this up. There was also some concerns flagged that if areas reverted to the previous process of requesting prescriptions from GPs, that this would add additional barriers and delays for people who are wanting to stop smoking, and it doesn't necessarily result in this seamless pathway. And then finally, we had feedback from primary care prescribers who they expressed concern that they just did not have the capacity to respond to prescription requests from stop smoking services across the whole of the North East for both Varenicline and for Cytisine. So myself and the two public health pharmacists who were leading on this, we submitted the formulary review application with a note of intention that in the medium term, all of our stop smoking services would supply prescription-only medications such as Varenicline and Cytisine independently without requesting prescriptions from GPs, as this was viewed as the biggest barrier to getting approval onto the formulary. The application was officially supported by the Smokefree NHS Task Force in the North East and North Cumbria, by all of our trusts, our clinicians, and also by the ADPH Tobacco Commissioners Network. It was submitted in June and was approved in October following due process of consultation and going back and forth to the different groups. So we then looked to work with our Tobacco Commissioners Network to look at, well, how can we move this forward in our stop smoking services? We formed a task and finish group and we looked to review the previous PGDs that had been in place in our region. We looked to review the pharmacy dispensing tariffs and then developed a model to calculate the impact and cost of incorporating Varenicline and Cytisine through a PGD. In doing so, we used a number of assumptions. So, for example, we considered the stop smoking service data, the ambitions that were set for the local governments for quit dates set for next year, and we considered the cost and impact both at a locality level but also a regional level. Even taking into account our proposed costs for delivering the regional PGD, which include management fees, clinical assessment fees, product costs, the model suggested that across the region there would be a 6% efficiency saving in the total cost of all medications across the year. It suggested a conservative increase in quit rates of just over 4%, and this would result in more than 650 additional quitters per year in the North East. So based on this, the Task and Finish group took a proposal for a regional PGD, which all local authorities could sign up to and could benefit from the engagement of up to 555 pharmacies, as I say, across our region. This proposal was supported and agreed by all of our 12 local authorities. But what did it consist of? Well, in the North East, we have Pharmacy Services North East, or PSNE, I refer to it as. This is the provider company that was set up by local pharmaceutical committees, and it was established back in 2016 to help facilitate the commissioning of services within community pharmacy. Our proposal was that PSNE was commissioned on behalf of all of the local authorities to manage and deliver a pharmacy PGD supply service within the community pharmacies in the North East. And this was based on something similar that we'd done previously to enable a maternity NRT e-voucher supply across the whole of the ICB. So to do this, the proposal included identifying a lead local authority. There would be an MOU in place between the lead and all of the local authorities, and the lead local authority would be the one that authorised the national PGD template through their own governance and procedures, which the other local authorities would then adopt. The lead local authority would then contract with PSNE, as I say, on behalf of all the local authorities, and PSNE would engage with the pharmacies and sign them up to deliver the supply service. They would also develop an e-recommendation template on farm outcomes based on the PGD and provide all of the locality stop smoking services with access to farm outcomes so that trained stop smoking advisors across the region could utilise it and make e-recommendations for clients wanting Varenicline. The client would then go to the pharmacy who would do the clinical check, and if appropriate, the pharmacy would then issue the supply. And instead of localities receiving up to 60 different invoices per month from different pharmacies for the product supplies, etc., localities would just receive the one invoice from PSNE, and then PSNE would sort the payments out to the individual pharmacies. There were multiple benefits from this approach. From a local authority perspective, it was much more efficient. Previously, where local authorities had put PGDs in place, it was a lengthy process that required lots of capacity to develop the PGD, to develop and amend service specifications, to engage with individual pharmacies, develop or processes or buy licenses for systems, deliver training, etc. And all of this took a lot of time and capacity within the public health teams, which were increasingly under more pressure with more portfolios to manage. And then obviously having to do that separately in all 12 different local authorities. This approach meant that things could be done just once. It was a consistent approach across all of the localities, and it also meant that there was a singular approach to training could be taken rather than, training being done multiple times in each of the different local authority areas. There was also a huge benefit in terms of from a pharmacy approach. It was a single consistent approach. Staff within pharmacies often work across multiple pharmacies, and sometimes they can work in multiple pharmacies that are in different local authority areas. So they would no longer be subjected to this kind of postcode lottery of, well, in this shop you can offer this, but in this shop you can't. And it would also mean that it was the same process in every shop, in every locality, using the system that the pharmacies were really comfortable with. And this makes it much, much easier for pharmacies and for their staff, meaning that they were more likely to engage. I think what we noticed was when things start to get really complicated or there's various different systems or processes being introduced, that's when we see the pharmacies maybe pulling back and disengaging. But finally, the biggest benefit is to the person who smokes. As I say, we put them at the heart of everything that we do, and this proposal would give them that consistent access to evidence-based first-line stop smoking medications. It would provide them with greater choice and greater flexibility, and remove the barriers of having to get an appointment with a doctor or waiting on a prescription to be request to be turned around, or only being able to access a certain clinic at a certain time in a certain location because there was a prescriber there. It also, because it was regional, it would also remove the artificial local authority boundaries. So, for example, if somebody lived in Northumberland, but they worked in Newcastle, they could access a pharmacy in Newcastle, maybe on their lunch break, even if they were being supported by the Northumberland Stop Smoking Service. So, as I say, much more flexibility there. I just wanted to flag as well that whilst we're working on this regional pharmacy PGD supply service for community stop smoking services, we were also very much aware, as I say, that the landscape of the stop smoking system in the North East was much wider. So we wanted to ensure that Varenicline and Cytisine were available in our Trust's tobacco dependency treatment services as well, recognising that people in the community will be admitted to hospital and people in hospital will be discharged back into the community. What we didn't want was a situation where, for example, Varenicline could be accessed in hospital, but then it couldn't be continued in the community, or vice versa, somebody being initiated in the community, but then being admitted to hospital and not having the medication there for them. So we have this parallel work stream within the trusts working with our Smokefree NHS task force. We've developed a template standard operating procedure for the provision of both Varenicline and Cytisine. These have been approved by our task force and they've been shared with the tobacco dependency treatment services across our acute and mental health inpatient services. And the tobacco dependency teams within each of the trusts are currently looking to go through the process of through their internal governance procedures to localise and adopt and ratify them. So this is our anticipated time plan. As you can see, the plan is to launch in early February next year. However, I would be remiss if I said that everything has gone smoothly. We've had lots of enthusiasm, willingness to collaborate across the region and support across the system from commissioners, stop smoking services, clinicians, pharmacists, LPCs, PSNE, and amongst others. We've made great progress we've have everything ready and waiting to go. We have the MOU, we have the contracts, the service specs, the amended PGD, the recommendation templates, training plan. but it's not without its challenges. And I think, you know, it's fair to say that the biggest challenge that we have actually is procurement, the actual process of within a local authority being able to contract and transact money across to do direct awards, involvement of legal teams. Obviously, there's new rules and new regulations coming out around procurement, and the bandwidth to understand the new rules and how we can move forward with them. So, you know, if anyone anywhere has found an easy solve to this, then definitely please do get in touch. It would be welcome. As I said at the start, this is a work in progress. We have everything ready to go for a start in February, but we still need to work through and finalise with a lead local authority. And if that's not done, then we obviously do risk our timeline being delayed. And I think on that note, I will end it there. Thank you.
Joanna, thank you. I mean, that is an outstanding piece of work. And again, lots of claps coming for you, because I think one of the things with Varenicline and Cytisine is because hospitals already have prescribing in, we're used to prescribing medications, it's part of the day job. That's not the case in local government, but our patient pathways straddle both. And for a lot of people, they only access local government. They've not even touched a hospital. So the work that you're doing is just outstanding. And I can imagine that you're going to be booked up to give regional talks. And this, you know, Ash and others have long pushed for regional tobacco control structures to be more mature, as you've got in Manchester, as you've got in the northeast. And this is almost that proof of that kind of concept of regional tobacco control, allowing things to be done once and everybody to benefit, provided you can bring everybody together. And so I know you're not there yet, but it feels like you're within touching distance. So thanks ever so much. I'm sure Ash and others would be keen to hear how this goes, and I'm really going to cross all, you know, my fingers, my legs, everything, to in the hope that you get it launched. So just outstanding. Thanks ever so much. So next up, again, another piece of the puzzle that all of us face when it comes to introducing new things, new treatments, new intervention, is training for our staff who are tobacco dependency or stop smoking advisors, training for healthcare workers if you're working in the NHS, training for others. And of course, the NTSCT, this is their forte. They've been doing training in this area for decades now. And I'm very pleased to introduce both Sophia Papadakis and Louise Ross to talk about the training and resources available through the NTSCT. So Sophia, over to you.
Good afternoon, everyone. I've really enjoyed the talk so far. So great to see the lessons learned and the challenges being faced together. Let's talk for a few moments about training and what's available, in addition to training resources. We now have our suite of first-line tobacco dependence treatments, and front and center there, figuring in there, are our nicotine analogs, Varenicline and Cytisine. A reminder that these medications work on their own, but when combined with behavioral support by a trained healthcare professional, or in the case of community stop smoking advisor, they work even better. And it's been said earlier, I think almost everyone in their presentation echoed this, the importance of making sure that our patients, our community members have access to the best available treatments, and that be done equally across the country with the great work happening. To signpost to a few resources that have been published very recently and some that have been around for a while, but have been updated, we wanted to talk a little bit about the local stop smoking services support commissioning, service delivery, and monitoring guidance. In that document with the web link that's here, that was published, updated, it's the 10-year update this past March, you will find a number of evidence-based summaries. So if you're looking to, as Matt spoke earlier, make sure you've got easy access to the latest evidence and position. If you're in community, likewise, for commissioning purposes, this document is your go-to. The link is there. Everything we spoke about this morning in previous presentations as it relates to why we're introducing this treatment and what the urgency is around it is summarized in that document. This is a summary from there that's pulled from the Cochrane review that Matt referenced earlier. And I want to remind us as we think about it, also in this document are the behavior change techniques that we use in both inpatient, outpatient, and community settings as it relates to supporting our residents who smoke with stopping. One of those behavior change techniques that are around this circle is advising on stop smoking medications. And it's one of several things we do to help individuals quit, but we know it bears a significant weight on their ability to quit successfully. It is a behavior change technique because we can prescribe the medication, but in addition to that, we want a workforce of healthcare professionals that knows how to advise on the correct use of that medications. And so increasing prescribing confidence, but also throughout the course of using that medication, discussing those medications, that we all feel really comfortable with how to do that well, and what are some of the nuances around using these medications. So on the screen here are some of those nuances, if you will. Spoken to earlier is making sure that people understand what their options are, what might be best suited to their needs. We know our nicotine analogs for more heavily dependent individuals, those with past use of one of the other therapies, may benefit from using Varenicline or Cytisine on this next attempt. Having realistic expectations around the medications as well is one of the jobs that we need to make sure we are doing well. Providing proper instruction around its use and how we deal with some of the side effects so that you are informed, but also many of the side effects that are experienced with our nicotine analogs can be well managed with a couple of quick techniques. So making sure all of our field of workforce are aware of that and can help people stay on these medications should there be some of these common side effects experienced. And they don't occur with great frequency. When they do, we've got strategies. Using enough for long enough, so when we need to extend doses, and as well making sure we can adjust treatments as needed going forward. This is really what the training that we're going to be talking about seeks to make sure the field is ready to address. So a little on the training resources that you can access today, and in particular access from the NCST website. These are training resources that almost everyone on the call that have already spoken have contributed to developing, as well as many other experts across the country. They happen to be held right now on the NCST website, and you'll find them by looking up under guidance, stop smoking medications. So there's a tab there with a drop-down menu, and all of the medications are listed there, but in particular, Varenicline and Cytisine, you can quickly identify training and resources that are there. A little known tool that's hiding there and might be useful is our quick reference sheet, of which a screenshot is available here. And earlier this year, Cytisine was added to that. That's one of those quick references that all clinicians who are either prescribing or supporting use of the medications may want to know about. It means we don't need to remember everything right away as something new is introduced to field, and it's the kind of laminated sheet that some individuals might benefit from. We have a number of e-learning courses, some directed to the inpatient setting, some directed to community setting, and all have been updated to reflect the availability of Varenicline and Cytisine and the education we all need as a workforce to be up to date on these medicines and how they're used. A reminder that the NCST has an e-learning platform that is available across the UK in all countries, that it's free. You do need to register, open an account, and that's about it. You are ready to go and you'll be able to access a suite of e-learning, one of which is our Stop Smoking Medications module. If you've done that training before but want to see again the Varenicline and Cytisine sections, you can do just that. You can go directly to that section of the e-learning and access that. Likewise, our Stop Smoking Practitioner training, the National Certification of Stop Smoking Advisors, has been updated to include Cytisine. It has always included Varenicline, and there you'll be able to see in both training videos of how we explain the medications, what we do when we experience side effects, and any practical details that can support clinicians with the skill of an art and science of speaking to patients and community members about the medications. There is also an inpatient e-learning. It's being launched in the days ahead. I don't have a final date for you, but it also includes a module again on stop smoking medications where for our NHS colleagues that will be available to you and at your fingertips. Here are some screenshots from the training, and you can see there are a number of film clips that demonstrate conversations with patients and community members. And here's a screenshot of the e-learning with a link to that for NHS. In addition to e-learning, I want to let you know that there is a PowerPoint deck that can be downloaded from the NCST website that includes our nicotine analogs. So from everything but why we use them, how they're used, their mechanism of action, in high quality slides. This is an NHS NCST partnership that allowed for these slides to be developed, but they can be downloaded from the website for, if you will, internal meetings, education events, and they're short, sweet decks that get to the point around prescribing in some of the key issues. Some screenshots here. There is also a briefing on cytisine, a newly published briefing several weeks ago. It was announced, and that can be accessed via this link. Provides you dosing guidance and other key pieces of information. So to signpost you to that, I think is all we want to do. In addition, there is a short, very short film that talks about cytisine, really just to help introduce it to the field and the workforce. You can see the speakers that are here, but to let you know that that's there, and again, can be accessed via the Stop Smoking Medications tab of the website. So I'll stop there, and just 2 final slides. I'll turn over to Louise Ross to say a few words. Louise?
Thanks, Sophia. That was so good. Yeah, and I'm very aware while we've been talking and reading the chat along the sidebar, just how many services are experiencing frustration about needing to get cytisine and varenicline onto their local formularies. And you know, this is something totally would happen just now, wouldn't it? Dog barking. It's something that we get requests for information about all the time from not only stop smoking services, but from patients as well, saying, you know, I'm desperate to get hold of some cytisine. How do I do it? Because my GP sends me to the stop smoking service. They say they can't prescribe it. And so the patient is going backwards and forwards. And my advice would be, get somebody really senior in your organisation. This is to Stop Smoking Services. Get somebody senior in your organisation to start getting onto the medicines management team of the ICB and say, you know, this is a priority, because it clearly hasn't been made a priority in many areas. You know, they're probably dealing with other really important stuff, but for your patients, for your clients, for your people who smoke in your area, they need another choice. Nobody is going to do that for you, and you know, this is very clear that, you know, when you've got somebody like Joanna Feeney on your side, you know, working day and night to get availability of these new medications, that's great, but it's a lot of work. And somebody needs to take responsibility for that in your local area. Otherwise, people will just carry on smoking because the choice that they would have made isn't available. Can you slip to the next slide, please, Sophia? Thank you. Because we know that most people who smoke are looking for some magic solution. They think that this next thing, this new thing, will be the thing that works. We know that there is no magic, but we can inspire people to put their trust in the treatment plan that is going to be devised for them. Important as well to ask each service user or client for some honest feedback about how this worked for them. We need to know, you know, did it work? Try and get them to come back at the end of their quits to say how it felt, the side effects, you know, any difficulties that they had, the dosing regime, for instance, because we can use those lessons to increase the confidence that we instill in our clients going forward. Thank you.
Great, that was it for us.
Great, thanks very much. So I'd like to thank all of our speakers. I think we've had a lovely canter through a variety of areas, from Matt in Manchester and the team in Manchester doing fabulous work with the various NHS trusts there, and the regional permissions that they've worked on. We then had Kieran with the work that the specialist pharmacy service has done to try and make it easier for everybody to and produce a template for a national PGD for Varenicline and one on cytisine coming soon. the amazing work that Joanna's done with Fresh and Balance in the Northeast. And I think that, Joanna, that's a real model that lots of regional groups could do to support local government services. I know in the Midlands we've got, I think, 25 local government services, and it would be great if we could sort of do once and share with the same model and learn from you. And I'm sure you'll, it's similar in London, for example, and in other regions too. And then, of course, last but not least, Sophia and Louise and all the amazing training resources. Lots and lots of information for people to take in. I know that Ash are planning to share a link of the recording and other resources on their website. I know that people have been answering questions as we go along in the chat. We've got another 15 minutes for chat. But I think what I'll do is, while people come in with questions, and Claire, I don't know if you can help out with questions that you've spotted that we've not yet answered.
So I posted a list of questions in the chat, so ones that we've picked out that haven't been answered just by our speakers or by other attendees, if you'd like to pick them out. There's 10 of them so far. Okay, so maybe I will pose them then. So I understand neither medication is suitable for the under 18s. Can you speak as to why? Well, I think that would be purely because of the way the clinical trials were done. Generally, these medications are only trialed in adults. That's not to say that they couldn't be used, but they would have to be used off license in people who are younger than that. I know cytisine, for example, shouldn't be used in people who are over 65, but we do use them off license in people who are older than 65. And it's really to do with how trials are put together and the funders for the trial that we often have these types of exclusions. So question 2, does it also cover community stop smoking services? I believe there is a barrier for community stop smoking teams that they have a band for advisor who can prescribe NRT, but the two drugs have no professionals who are qualified. So I think that's to do with PGDs, Kieran, that's probably one for you. And with NRT, my understanding is because you can get it over the counter, PGDs, you could use PGDs to provide NRT on wards and other non-professional groups. But yeah, I'll leave it to you, Kieran, to answer that one.
Yeah, so non-registered staff can supply rather than prescribe NRT because it is a general sales list medicine. So it's not under a PGD, it's under a protocol or a trust-based or local authority-based policy. And yes, PGDs have to be used for prescription-only medicines. They're enshrined within legislation, and it can only be a registered healthcare professional who can work under those. So policies and protocols have no legislative footing, so it's a free-for-all.
Yeah. I mean, I think, Joanna, you tried to address this with some of the work that you were doing, weren't you? Do you want to speak to that? So local authorities using a regional PGD, you seem to be cracking that one.
Yeah, so I mean, obviously within the PGD, you do have to be a registered healthcare professional in order to utilise it. And in our stop smoking services, as I say, there's 12 different types of services, different models. Some of them do have registered nurses. Some of them have a couple of nurse prescribers. But what we wanted to do is we wanted to make it equitable across the board. So it doesn't matter how the service is delivered, the band of the advisor, whether it's delivered, outreach, specialist service, which was the reason that we came up with the pharmacy supply PGD model. So it was working with our colleagues in community pharmacy as the pharmacists being the registered clinician there.
And I think that's a great model, actually, and it'd be great if we could unlock that at a national level too. Matt, I think questions 3, 4, and 5 are for you. I don't know if you can pick them up in the chat.
Yeah, I can. So, Varenicline with NRT, offer your stance of use, but concurrently in the efficacy of it, as both work differently. So, I think it's just the specific scenario of an inpatient setting. That's where it feels so useful. So an outpatient setting, that person continues to smoke, and as Varenicline's reaching its maximal effect, the smoking should come down. And so Varenicline is ideally by day 14 that they set a date to stop, though it can be, some people need longer than that. Cytisine's day 5, but there is an initial period where acknowledging that it's likely additional nicotine is needed. But in a smoke-free environment, in the inpatient setting, that has to be from an alternative source. So I think it's why the BTS statement is designed exactly as it is. It really states the importance of how rapidly we need to get people onto combination NRT to mitigate withdrawal from the very moment of admission. Most will be withdrawing and suffering from withdrawal at the point of admission or very, very soon afterwards. And NRT is so readily available, we get that prescribed in combination as soon as possible. But the data, everything we've heard today about how effective Varenicline and Cytisine is beyond that of NRT. So offering all the patients we meet the opportunity to access those treatments is the right thing. And for those where it is right and it is appropriate, we start that in addition to the NRT. So I think it's just that unique scenario being in a smoke-free environment in a hospital setting. The two things just work well together.
Can I just come in there, Matt? And also we do have efficacy data from local government stop smoking services that demonstrate the combination therapy of NRT plus either e-cigarettes or Varenicline are actually more effective than each of them on their own. So there is efficacy data as well.
May I jump in just to say?
May
I jump in just to say that if anyone's looking for a summary of that, both the BTS guidance and the local stop smoking service guidance have a section where we provide references and a good solid summary of what we know and don't know about combining the nicotine analogs with NRT.
Great, thanks, Matt. The next one is also, I think, for you. How is the prescription titration of the course managed once a patient has been discharged from the hospital setting? So I suppose this is about follow-up. So how do you guys do it in Manchester?
So it's such a well-described prescribing regimen. So Varenicline comes in an initiation pack of the 14 days. It's got the first week of titration, and then that person's on to the 1 milligram BD, all within that initiation pack. So 14 days of that, and then they've got a maintenance pack for the rest of the 10 weeks. So we do, as we would with any other medication, education with a patient, supportive information and patient information leaflets. We've heard lots of good resources today that go through those regimens. Cytisine's the same, it's a bit more complicated, but the NCSCT have got a really nice diagram that we use. I think everybody uses it, of the 6 down to 2 tablets, where patients can actually tick off by the days. So it's never really been a barrier of a patient not being certain or sure how to use it. I think it's relatively straightforward. And the follow-up, because because we're providing the full courses, it's then so suited to telephone support and follow-up beyond, where you can provide the behavioural support alongside it. And we can check in on how things are going with the medications.
Brilliant, thanks. Matt, right, and then there's a question about funding. Just very briefly, Matt, do you want to come in, because then we'll also try and get to some of the others as well.
Yeah, so it's within the trust funding. As I said, I've really tried to highlight the point of the cost-saving element to it. We're already providing treatment courses, and that it's been cost-saving against those.
Brilliant, thank you, Matt. Kieran, I think you've got the next question, and it's sort of saying, I think, why is the PGD for Varenicline so kind of focused on monitoring various other drugs if people stop smoking with Varenicline, whereas we don't have these same requirements for NRT, it would seem?
So there's lots of published evidence which suggests that metabolism of a range of medicines is affected by stopping smoking. And some of these are quite serious, so clozapine being the most high risk. And there are others where there is huge interpatient variability. So one patient may develop side effects, but the next patient may not. We were really aware that developing this national PGD template, we didn't want to rewrite national policy on this, and we wanted to highlight to people that there may be a risk with some of these medicines, especially those within a narrow therapeutic index. So it's to kind of make people aware again of the importance of just counseling patients of the risk of side effects and looping back in with their stop smoking services, who then may need to contact a GP or prescriber to amend the dose. So we are aware that in lots of services with NRT that it doesn't happen, but that doesn't mean that it doesn't happen with patients, and they may, we just want it to be as safe as possible.
Okay. I think the question was about the disparity between stopping smoking by some other means versus Varenicline. And
it should be the same.
It should be the same, but it wasn't actually. And then I suppose there's another question for you. The safety of Varenicline in pregnant women. I mean, I think we can't really do much about that. If it's been excluded based on the trial, there's not much more to say about that, really. It's a contraindication. I'm rattling through the questions here just because I know we've only got a few minutes there. Sophia, if you wanted to come in on one of these points.
Would that be okay? I just wanted to echo what Kieran has said, but maybe a point of clarification, because for everyone on the line, it is not these medications that causes that interaction, is the tar in smoking, because we often get that confused. And I think when it's inside of a PDG, it can be even more confusing. So the medication interactions that Kieran just spoke about in the questions relating to that, in particular psychotropic medications, is not related to Varenicline, Cytisine, or NRTs, but rather stopping smoking. So I just want to make sure we don't again lose sight of that important fact.
Yeah. Now, the next three questions, Joanna, are kind of, well, certainly 9 and 10 are, I think, related to the work that you were describing. And again, one's about antipsychotic dosing. So did you want to take question 9 and 10, and then maybe I can come back to question 8?
Yeah, sure. So, I mean, we had a lot of discussion in terms of, obviously, we are utilising the national PGD and recognising that there's only a few parts in the national PGD that you can actually amend. We've taken the decision to exclude patients who are on high-risk medications from the PGD, but we do include the medium-risk medications. With the PGD, what we are looking to build into the templates on farm outcomes is a flag, so an automatic email to go to GPs informing them that the person has been issued with the medication. If they're flagged as having one of the medium risk medications, this would be the same process as stop smoking services do in their for any other quitters, nicotine replacement therapy. It will flag that they are on this medication, and it will ask that the GP, if they have any concerns, to contact the stop smoking service within 7 days. So that's actually before they've actually stopped smoking, for example, with Varenicline. So it gives that bit of information there. One of the things we did talk with our, when we spoke with our primary care colleagues, was that, they felt that actually, if it was somebody who was on was on, for example, clozapine, they weren't the experts in terms of the dose reduction. So it was needed to be very much a kind of a partnership approach, working with secondary care colleagues, mental health colleagues, and prescribers there as well. So I think, as I say, for us, we have used the national PGD. What we're trying to do is put some processes in place to make sure that no one is excluded completely. People on high-risk medications won't get it, the products through the PGD, but they can get it through through the close working relationships with the prescribers, whether that be primary care or secondary care mental health services. And then just in terms of the cost of the farm outcomes licenses, this was one of the reasons why our proposal included working with colleagues within Pharmacy Services North East, because that would actually be as part of their contract management. So the cost is the equivalent of £50 per pharmacy to contract manage it, and that would include the licensing and would give so that local authorities don't need to build in and pay for a licensing for additional systems as well.
Brilliant. Joanna, I'm going to try and pick up the last couple of questions. There's quite a lot, though. The one question is about GPs, and there doesn't seem to be an equitable service provided by GPs, and I think Louise touched on this as well. And so some GPs will provide prescriptions for local government stop smoking services, some won't. I think that's because the funding models for general practice are quite different. So, for example, for hospitals, and that's why I think the work that Joanna's doing with community pharmacists is to bypass GPs might be quite helpful. So that's something I suggest we would pursue. I know there was another colleague of mine from Northamptonshire who was looking at an online pharmacy option and contract that might also solve that problem for local government, whereby the local GPs do not feel able to provide. There's another question from Claire Mellon, my colleague in Leicester. It's not a planted question, but it was a genuine question. To be able to pull out data into the national reporting template on the use of cytisine and varenicline, is there a SNOMED code for this? And I don't know if anybody knows that. Kieran, you're smiling. I'm hoping. I don't know if that's
I don't know. No.
No, you don't. Okay, maybe that's one that we can put in the Q&A and hopefully get an answer for, because that's to do with reporting back to NHS England and using the electronic systems to not have to manually input data on those patients who've received cytisine and varenicline, and how can we do that? And then let's see, safety of medications and people performing undergoing rehab. I would say it might sound a bit flippant, but probably these medicines to help stop smoking are safer than continuing to smoke. So in general, you know, the only people I don't maybe prescribe things like NRT to. In fact, there isn't really anybody I don't prescribe NRT to. So I would say that a lot of those BNF warnings are probably related to original trials rather than actual clinical importance. So I think I'm probably going to stop us there. We've just gone over. It's been a fantastic webinar. Thanks to all our speakers. Thanks for all the brilliant questions. Thanks for the team at ASH for putting it together. It feels like we're going to need another one of these at some point in the future. And I think speaking to the team at ASH, once cytisine becomes fully approved by NICE in February, maybe we can arrange for another webinar sometime after that. But thanks everybody for a brilliant webinar. Really helpful.
Thanks everyone. Bye-bye.
Thanks. Bye.